Medical consultations are among the highest stakes conversations in any language. Misunderstanding a diagnosis, failing to disclose a symptom, or not grasping the implications of a treatment plan, these aren't communication failures. They're risks to life.
For advanced English learners living, studying, or working abroad, navigating a medical consultation is a critical real-world skill that most language courses completely neglect.
Welcome to Advanced English in Context. Today's episode covers medical English, a vocabulary set that spans formal clinical language, patient-accessible explanations, and the empathetic register of doctor-patient communication.
Conversation 1. A patient presenting with ambiguous symptoms to a specialist. Conversation 2. A doctor-to-doctor case discussion in a hospital multidisciplinary team meeting.
2 registers, 2 audiences, both requiring precision, composure, and the ability to handle uncertainty without projecting alarm.
Conversation 1. I'm Dr. Moore, a neurologist. Sarah, you're the patient, Claire.
Dr. Moore, thank you for seeing me. My GP referred me because I've been having persistent headaches for about 3 months, not severe, but they're almost daily and nothing seems to touch them.
Thank you for that overview. When you say persistent, I want to understand the pattern. Are they constant throughout the day, or do they tend to peak at certain times? And where exactly is the pain localized?
They tend to peak in the late afternoon, and the pain is mostly at the back of my head and into my neck. Sometimes I get a kind of visual disturbance, like a flickering in my peripheral vision, just before they intensify.
That visual symptom is significant. What you're describing, particularly the flickering before the headache intensifies, has the hallmarks of a migraine aura. But given the persistence and the posterior location, I'd want to rule out a few other things first.
Rule out what, specifically? I don't want to catastrophize, but naturally my mind goes to the worst-case scenarios.
That's completely understandable, and I want to be transparent with you. We need to exclude elevated intracranial pressure and any structural abnormality. The likelihood is that this is benign, but we need imaging to be certain.
What kind of imaging are we talking about?
An MRI with contrast. It gives us a detailed view of the brain's soft tissue. I'll also order blood work to screen for inflammatory markers. If everything comes back clear, we can move toward a confident migraine diagnosis and a proper management plan.
How long will results take? And in the meantime, is there anything I should be monitoring? Are there red flags I should look out for that would mean coming back sooner?
Very good questions. Come straight in if you experience a sudden onset severe headache, what we call a thunderclap headache, any loss of vision, weakness on one side, or difficulty speaking. Those warrant immediate assessment.
That's really helpful framing. I feel much more prepared now, both for what to expect and for what to watch out for. Thank you for explaining things without glossing over the uncertainty. Let's break down key medical vocabulary. Hallmarks of this phrase indicates the defining characteristics of something. The hallmarks of a migraine aura include visual disturbances, sensitivity to light, and a preceding phase before the headache. It's widely used in medical and non-medical contexts.
Rule out is a core phrase in diagnostic medicine. When doctors rule out a condition, they eliminate it as a possible diagnosis through testing. We need to rule out a cardiac cause, common in clinical language, also useful in professional English generally.
Red flags in medicine are symptoms that suggest a serious underlying condition. Outside medicine, any warning sign. There were red flags in his behavior. The financial report raised several red flags. It's one of the most versatile idioms in English.
Glossing over. When Dr. Moore explained uncertainty rather than glossing over it, Claire felt respected. In any high-stakes conversation, glossing over means skimming past difficulty or discomfort. Avoiding it builds trust. Conversation 2. A multidisciplinary team meeting at a hospital. I'm Dr. Farida, the oncologist. Sarah, you're Dr. Chen, the radiologist. The patient is a 63-year-old male presenting with a suspicious pulmonary nodule incidentally identified on a CT scan ordered for something unrelated. Dr. Chen, what's your read on the imaging?
The nodule is 1.8 centimeters with irregular margins and mild pleural traction. The density and morphology are consistent with a primary malignancy, though I can't exclude a granuloma. The patient's travel history would be relevant here.
He's lived in Southeast Asia for 10 years, so endemic fungal infections are on the differential. I'm inclined to proceed to PET-CT before biopsy, gives us metabolic activity data and may inform the staging simultaneously.
I'd agree with PET-CT first. The metabolic data will help stratify the risk before we commit to an invasive procedure. If the SUV is high, we proceed to CT-guided biopsy. If it's low, we could justify a watch-and-wait approach.
Agreed. I'll also loop in thoracic surgery today. If this turns out to be stage 1 adenocarcinoma, we'd want their input on resectability before the patient is aware of the full picture.
What's the plan for disclosure? How do we communicate staging uncertainty to the patient without causing unnecessary distress?
Carefully and honestly. I'll tell him we've found something that needs investigation, that we don't yet have enough information to say more, and that we'll reconvene with a full picture within the week. No false reassurance, but no projecting alarm either.
That's the right approach. Patients generally handle uncertainty better when they feel that the team is thorough, coordinated, and honest. It's the unknowing that's most distressing, not the unknown.
From the clinical discussion, on the differential. In medicine, the differential diagnosis is the list of possible conditions under consideration. X is on the differential means it's a possibility being actively considered, not yet confirmed.
Stratify the risk, a phrase from statistics and medicine that means to divide a population or set of cases into categories based on risk level. In clinical language, it enables prioritization. High-risk patients get faster intervention.
False reassurance, one of the most important concepts in medical ethics. Telling a patient, "I'm sure it's nothing," when you're not is a form of dishonesty, even if kindly intended. Calibrated uncertainty is both more ethical and more helpful.
And the memorable closing, it's the unknowing that's most distressing, not the unknown. This distinction captures something profound. Not knowing a fact is manageable. Not knowing that you don't know is far more anxious-making. Slow repeat. First, nothing seems to touch them. This is an idiomatic phrase for when treatments have no effect. Learn it. It's natural, expressive, and commonly used by native speakers in medical contexts.
Stress. Nothing seems to touch them. You can also say, "Nothing seems to help," "Nothing makes a dent," or "Nothing I take makes any difference." Practice. Nothing seems to touch them.
Second, I want to be transparent with you. We need to exclude elevated intracranial pressure and any structural abnormality. The likelihood is that this is benign, but we need imaging to be certain.
This sentence models the structure of honest clinical communication: transparency of intent, statement of concern, calibrated reassurance, and next step. Slow. I want to be transparent with you. We need to exclude elevated intracranial pressure and any structural abnormality.
Quiz. Question 1. Claire said that nothing seems to touch her headaches. What does this idiomatic phrase mean? A. No one is addressing her headaches. B. No treatment or remedy appears to have any effect. Or C. Her headaches are not physically located in one place.
Answer. B. Nothing seems to touch them means that no remedy, medication, rest, or other treatment appears to reduce or relieve the headaches. It's a vivid and natural way to express treatment resistance.
Question 2. The doctors discussed stratifying the risk before proceeding to biopsy. What does this mean in clinical practice? A. Reducing the patient's stress. B. Categorizing the level of risk to decide on the appropriate level of intervention. Or C. Ordering all possible tests simultaneously.
Answer. B. Stratifying the risk means using available information to classify how serious a case is, so that the right level of intervention is applied, avoiding both undertreatment and unnecessary invasive procedures.
Medical language, whether you're a patient or a professional, demands both precision and humanity. Today's episode has given you vocabulary that serves both.
Join us for our final episode in this series, discussing economic inequality, one of the most complex and contested topics in public discourse. English 066 awaits.